I see that we are, I think, getting critical mass here, so I think we should go ahead and get started. I want to welcome everyone today to this session. Good morning, good afternoon, and good evening to those joining us around the world. My name is Catherine Shelley, and I'm a Deputy Director in the Primary Healthcare Program at PATH and Project Director for the Asset Tracker Project. I will be serving as the moderator today. Although there has been progress in reducing preventable maternal and newborn deaths globally, and many high-impact interventions exist that are cost-effective and well-known, there are barriers to bringing these interventions to scale and ensuring they reach the last mile. Data is often a critical missing piece, preventing further progress on maternal and child health. And more often than not, data is not readily available to advocates and policymakers, leaving them without the information needed to best design policies, to allocate resources, and ensure quality program implementation. Where data do exist, access can sometimes be restricted or quality control can be lacking, or those who need it are not aware of the data. And even when available, decision makers often do not have the tools to quickly access or analyze the data. For example, through dashboard visualizations or trackers. In order to help improve data use and access to data, PATH undertook an analysis of access, uptake, implementation, and coverage of 22 key maternal, newborn, and child health and nutrition commodities, tools, and approaches, or what we collectively refer to as assets. The project helps decision makers and advocates to better use data to improve maternal and child health and save lives through evidence-based policy. Today, May 22nd, is World Preeclampsia Day, an important advocacy moment for this raising awareness of this pregnancy complication that causes high blood pressure during pregnancy or after giving birth. To enrich our conversation today, we have a lineup of key speakers that will present on Asset Tracker findings, including the status of scale-up of calcium supplementation and low-dose aspirin, two key antenatal interventions for preventing preeclampsia, as well as a dashboard live demo. And then we will also be hearing from two discussants for perspectives from a decision maker and a decision and policymaker, as well as an advocate. So our presenters include Kimberly Manson, a nutrition technical lead at PATH, Dr. Patricia Coffey, who's the Health Technologies for Women and Children lead at PATH, Lydia Nguti, the data manager for the Asset Tracker project at PATH. And additionally, I'm excited to welcome our two discussants, Zemzem Mohammed Yusuf, who's the National Maternal Health Program Coordinator at the Ministry of Health in Ethiopia, and Christine Yakahama, who's the Zonal Leader for the Kakamega County Maternal, Newborn, Child Health Civil Society Organization Alliance in Kenya. Thank you very much again for joining. And if you haven't yet had a chance to introduce yourself in the chat, we'd love to know who you are and where you're joining from. Great. So with that, I will provide a brief overview and background of the Asset Tracker before we move into the findings. Thank you. So to start us off, this project began in 2019 with funding support from the Gates Foundation and an aim of understanding progress towards scale of key interventions, or assets as we call them, through aggregating data from various sources, guidelines, surveys, and key informant interviews. Really focused on understanding barriers and enablers to scale. Overall, our approach has included a rapid literature review and data mapping, collation of secondary data sources. We also conducted global level and country level key informant interviews, all aimed at contextualizing the status of scale up. In each cycle of data collection, we've conducted deep dives in what we call focus countries. You see them listed here for this current cycle. And we've also aggregated survey data from a broader set of 81 of the countdown to 2030 countries. Throughout this process, there has been triangulation and synthesis of data to ultimately result in a publicly facing accessible dashboard with the aim of helping to spur conversation about the status of scale up, what needs to happen next, where to focus efforts to unlock bottlenecks. For more information on the project, you can access the link that's on this slide, and we'll also be putting that in the chat. Next slide, please. Thank you. So to date, we've looked at 22 different assets for improving maternal, newborn, and child health across the continuum of care, delivered in antenatal, labor and delivery, postnatally, or to infants and children. Some of these interventions have been around for a really long time. Others are relatively newer. I won't read through the whole list here, but today, as mentioned, in honor of World Preeclampsia Day, my colleagues will be highlighting findings from our review, a recent review of calcium supplementation and low-dose aspirin. Next slide. So this whole project has been organized around a framework towards scale. We reviewed many implementation science frameworks in developing this 6-stage framework on the pathway to scale, and we utilize this framework to anchor all of our data collection, analysis, and dashboard visualizations. You can see from the 6 steps that it's broken out from starting on the left with whether or not the asset is included in global guidelines and is available in the market, and then moving to the national level, looking at policies such as essential medicines lists and budgets to ensure the policy ecosystem is in place. Next, in terms of system readiness, we look at things like integrating the asset into the country's data system, training, and other health system components. Moving on, we also look at the rollout of the implementation of the guidelines. This could include supervision and mentorship, things that are needed to ensure high quality implementation. And then on the right-hand side, you see availability and coverage. So really ensuring that the product, the commodity, the approach is available and there's equitable access and coverage of that intervention. Next slide. So within each of the stages to scale of this framework, we have also developed key milestones, which you see listed below each stage. This is a view from our online dashboard. You'll be seeing more of this in the live demo later from my colleague Lydia. But just to say here that each milestone has associated indicators that we verified through document sources or through key informants or through secondary data sources. So with that, I will pass it over to my colleague, Kimberly Manson, who will present on findings for calcium supplementation. Thank you.
Great, thank you, Kath. And thank you everyone for joining today. We wanted to dive into one very specific asset or intervention that we explored. So as we stated, in honor of World Preeclampsia Day, I'll be sharing about one of the 22 assets investigated, which is antenatal calcium supplementation. Next slide. While many people are aware of iron and folic acid or multiple micronutrient supplementation during pregnancy as the key supplementation that is used, calcium supplementation is an often forgotten antenatal intervention. In fact, not everyone even realizes that calcium is not even in MMS at all. The addition of high-dose calcium as a supplement to women with low dietary calcium intake has been known to be effective in reducing preeclampsia by up to 50%. So WHO has recommended this intervention since 2011. It's been known that calcium has an impact for many years prior to that. And with the latest guidelines being released in 2018, the recommendation stands currently of 1.5 to 2 grams of supplementation of elemental calcium to women in regions with low dietary intake. So let's explore how the asset tracker methodology helps to tell the story of the current progress towards scale, as well as identify key barriers and facilitators of scaling implementation of calcium supplementation in pregnancy globally. So as we take a look across the asset tracker journey to scale, the framework, as you can see here, we can see that the calcium supplementation has met the indicators for global and typically national guidelines. However, as a generalization, and this is not in every country, calcium supplementation is getting stuck at that national guidelines level or stage and is failing to be fully deployed due to barriers to achieving system integration and readiness, implementation and service delivery, availability, and coverage. We have very little data to tell us this full story. But why are we seeing programs adopted at the national level and not rolled out? Let's explore some of the findings in the global key informant interviews around barriers and enablers. What we heard, and this is just touching the surface, But some of the key points that we heard are that the high dose regimen from WHO of the 1.5 to 2 grams of elemental calcium creates for an additional, it's 3 tablets per day to be prescribed during ANC beyond the traditional single IFA or MMS tablet. So that's already a triple of the times that you're trying to get someone to take something. Since calcium supplements are already bulky, the logistical concerns were raised as one of the key barriers for providing sufficient supplementation to all women. Actually getting the bulk and the transportation, storage, maintaining adequate stock, the provision of sufficient quantities to women takes a large effort of planning and actually making that happen. And there's not a lot of really good examples of that working well for countries to learn from. An additional barrier is that it's unclear which women should be receiving calcium, since the recommendation is conditional. Known dietary intake is not always available in regions or understood. We don't always have national level dietary surveys, for example, let alone the global guidance around what amount of calcium is adequate during pregnancy varies across the board. So the global standard for adequate calcium intake differs by source, and so it's been not made clear and has been noted to be confusing. And finally, another key barrier is the perceived cost of the intervention, especially when comparing this to the single IFA or MMS tablet for even in MMS, like multiple micronutrients. We're talking about tripling or sometimes more the cost because you're tripling the number of tablets being provided for just the one elemental calcium supplementation. Let's move to the next slide. So moving to data availability, what do we know around availability? When we're assessing the journey to scale, we were not even able to find routine indicators directly associated with calcium supplementation in the priority countries that we investigated. So without this data, we have no indication of actual availability, distribution, intake, adherence for pregnant women in LMICs. A simple strategy would be to add calcium supplementation to DHS surveys where they're already collecting information on other supplementation during pregnancy like IFA. So regarding access to products and pricing of calcium supplementation, it was actually quite readily available. We did quick checks in pharmacies in the various countries, and each pharmacy had a product that could be considered calcium supplementation. It came in all different forms, different dosage. It didn't necessarily align with the recommendation at the WHO level, but it was available. And the UNICEF supply catalog was actually the cheapest. It was a fraction of the price of what you're finding in pharmacies for purchase. Next slide, please. So where do we go from here? We know that many national guidelines incorporate the WHO recommendation for calcium supplementation, but it's not being rolled out. So what are some of the priority next steps for calcium to be standard consideration in the ANC supplementation package? Some of the key priorities and next steps include investing in platforms for improved antenatal coverage and ensuring that that covers all of the supplementation needs, not just for MMS or IFA. Without these strong platforms, reaching women early in pregnancy will be very difficult. And so this needs to be a combined approach, not just product focused. We need to be creating feasible dosing regimen and counseling guidance with improved formulation recommendations. Current dosage is perceived as too burdensome. In some studies, they were able to show that women were incentivized in pregnancy and actually took it with really good counseling. However, the general perception is that it's too much. And so just a recent publication released this year emphasized the non-inferiority of a lower dosage of calcium. So that may be an effective route for WHO guidance next. Simplifying the effective strategies for reaching and counseling women to ensure end user adherence. We talk a lot about the logistics of getting the product to ANC. Well, what about actually supporting and simplifying, prioritizing how that counseling is provided to the user needs. We may achieve the provision of calcium and yet fail to reach incentivizing women of knowing why this is important through optimal counseling methods. So with a reprioritization of simplified approaches and inclusion of calcium supplementation into global MMS and ANC-related interventions, the scale is feasible, leading to mother and infants' lives saved. We're going to present another asset in addition to calcium supplementation. So I'd like to welcome my colleague, Trish Coffey.
Thank you so much, Kimberly. And good morning, good afternoon, and good evening to all. As we celebrate World Preeclampsia Day today, I want to reiterate that hypertensive disorders of pregnancy, including preeclampsia, cause about 14% or around 76,000 maternal deaths worldwide every year. And when a pregnant woman experiences preeclampsia, infants also suffer. About 500,000 infants around the world die each year due to preeclampsia. Next slide. Importantly, we know that the incidence of preterm preeclampsia can be reduced by about 62% when low-dose aspirin is administered to pregnant women beginning in their first trimester. The World Health Organization guidance from 2021 recommends use of low-dose aspirin at 75 milligrams per day for women at moderate and high risk of preeclampsia, and that the administration of low-dose aspirin for the prevention of preeclampsia and its related complications should be initiated by 20 weeks gestation or as soon as antenatal care is started. The good news is that many low and middle income countries have already incorporated this guidance around the use of low-dose aspirin for the prevention of preeclampsia into their national guidelines and pre-service and in-service training. And some countries like Pakistan and Nigeria have recently created or are currently developing a policy framework for the prevention of preeclampsia that includes administration of low-dose aspirin. Next slide, please. When we look at the use of low-dose aspirin through the lens of the asset tracker methodology, we see that the intervention is facing challenges to system integration and readiness and implementation and service delivery. While many national guidelines may include the use of low-dose aspirin for the prevention of preeclampsia, awareness and use of the asset varies by geography and level of care. In some countries, providers at lower levels are not yet incorporating risk screening into routine antenatal care, which is required in order to identify which pregnant women will benefit from the use of low-dose aspirin. There is no clear consensus on the best screening protocol, since many groups like the WHO, FIGO, the Fetal Medicine Foundation, the American College of Obstetricians and Gynecologists, and the National Institute for Health and Care Excellence in the UK recommend somewhat divergent screening protocols in terms of required tests and clinical protocols in terms of drug dosage and when to start and stop administration. Other programmatic barriers relate to access to high-quality antenatal care. As I mentioned earlier, low-dose aspirin should be started early in pregnancy, and most women in low and middle-income countries start antenatal care later than the first trimester, so the optimal opportunity to intervene is past. An overloaded health system can further exacerbate this barrier, since those pregnant people that do present for care do not always get screened for risk of preeclampsia. During antenatal care, calculating accurate gestational age for use in applying the screening protocol can be challenging. Pregnant people often do not remember their last menstrual period accurately. And in many low and middle income countries, particularly at the lower levels of care, a lack of ultrasound equipment and imaging as part of antenatal care impedes obtaining accurate gestational age. Finally, low-dose aspirin can be seen by both providers and the community as an invasive drug with risks. Providers voice concerns around increased susceptibility to bleeding and miscarriage, and people don't always like taking drugs when they're pregnant. There are also some enablers to scale that have to do with refinements and implementation options. For example, a multi-country clinical trial to compare the efficacy of 75 versus 150 milligram low-dose aspirin for preeclampsia prevention is forthcoming. In terms of screening options, the Fetal Medicine Foundation offers a free online risk calculator that provides a clear numerical estimation of individual risk. Women may possibly be more likely to take low-dose aspirin if given a quantified risk estimate. Also, an affordable angiogenic biomarker point-of-care test is being developed, which could be integrated more easily into antenatal care. Next slide, please. This slide touches on the availability of both low-dose aspirin and data to track its use. Aspirin of various dosages is widely available in public and private sectors across our 5 focus countries. Illustrative pricing for low-dose aspirin is shown in the right corner of the slide. These prices are from private pharmacies, and some are comparable to what is being offered through the UNICEF supply catalog. Of note is that low-dose aspirin is not readily available in Burkina Faso, so providers recommend that the 500 milligram tablet be divided into 4 parts, which creates an approximate dose of 125 milligrams each. Measuring coverage of this asset is challenging since no direct indicators are included in the health management information systems in any of the 5 focus countries reviewed. Next slide, please. So what are the immediate next steps to advance the scale of low-dose aspirin for the prevention of preeclampsia? Generally, the way forward could be to support effective implementation of low-dose aspirin by strengthening antenatal care and provision of services at primary healthcare level and enabling the policy environment where needed. Specifically, efforts could focus on strengthening demand creation for antenatal care to increase early care seeking, possibly by enhancing communication or counseling around hypertensive diseases of pregnancy at the community level. Another point could be integrating point-of-care ultrasound devices, possibly including AI-enabled devices and other new and underutilized screening technologies into antenatal care. Also, creating a robust policy framework where needed, taking note that updating the National Essential Medicines list to include an indication for use of low-dose aspirin for preeclampsia prevention may be required. Now, I'll hand off to my colleague, Lydia Noguti, who will present a live demonstration of the Asset Tracker Interactive Data Dashboard. Thank you very much.
Thank you, Trish. And hello, everybody. I'm excited to take you through our Asset Tracker dashboard. And this dashboard was designed to help tell the story of the journey to scale of 22 assets, And the key component of this data visualization tool is that it can help you identify the key next steps along the Asset Tracker framework for advancing key maternal, newborn, child health, and nutrition interventions. So as we get into the dashboard, you land on the cover page, which serves as a table of contents. There are 2 ways to navigate our dashboard. You can either click on any of the 6 rectangles here or click on the tabs at the top. So for this demonstration, I will click through the tabs at the top and move to the next tab, which is the framework. So this is the Asset Tracker framework, which has served as the backbone of the investigations that we've been doing. And it showcases the 6 stages from the global guidelines through to the coverage. You can also hover over the milestones to get the indicators that were used in the investigation. I'll move to the next tab, which is the country progress tab. And in this tab, you get the information on how far along the journey to scale an asset is for a particular country. To change the view, I'll select an asset from this dropdown. In this case, I'll select low-dose aspirin and then the country. The colors of the milestone change according to how many of the associated indicators have been met. And when you hover over the milestone, you get to see the indicator, the data source, the year, and the finding. So when you're looking to have an in-depth look at how far along the journey to scale an asset is for a country, this is the tab you should use. I'll move to the next tab, which is the scale-up map, and this is a global map. Here, you're able to compare indicators across countries. And to change the view, I'll select again an asset from the dropdown. And in this case, I'll choose calcium supplementation. The next step is to choose an indicator from the list that appears on the left. In this case, I will select calcium supplementation in pregnancy in national guidelines. As you can see, there are two different colors, and each of them has a meaning. In this case, green means that the intervention is included in that country's national guidelines, and red means that the intervention is not included. And you can also see at a glance that approximately 50% or slightly more than half of the countries have this intervention in their asset guidelines. So when you're looking to compare the scale up of an indicator across countries, this is the tab to use. Next, I'll move to the second last tab that I'll be going through in this presentation, which is the Cascade tab. So in this visualization, we've woven together data from secondary data sources, mainly surveys, to tell the story of an asset's availability and coverage. So to change the view, I'll select from this dropdown an asset, and in this case, I'll choose low-dose aspirin. And the country, I will choose Ethiopia. As you can see in this chart, the first bar represents the proportion, the total eligible population, and which is that we would like 100% of all eligible to get the intervention. And 44% of all women had more than 4 visits, antenatal visits during their pregnancy. Next, we see that 26.9% of women had their first antenatal check before 4 months. And as has been presented earlier, this is important because this is an intervention that should be administered within that period. So the majority of women, 73.2%, had their antenatal care provided by a skilled provider, and 88.8% of all women had their blood pressure measured during their antenatal visit. From the data we could find, we realized that 24% of facilities had aspirin available, and unfortunately, we were not able to find specific coverage data for this asset. On the right here, we have a dailies table, which essentially tells you the proportionate contribution of each of these causes to mortality and morbidity in the country that I have chosen. And the row that is highlighted in the same color as the bar chart signifies that scale up and coverage of this asset may impact the cause that is highlighted here in the same color. So when you're looking to get the story of service delivery, this is the tab to choose. I'll move to the final tab that I'll be going through in this presentation, which is the time series tab. So in this tab, when you're looking to see how an indicator varies over time, this is the tab you come to. So I'll demonstrate by choosing calcium supplementation from the asset dropdown. Then I will choose a country. So in this particular view, you can choose 1 or 2 countries. So I'll choose 2 just to give a demonstration. And then finally, you choose the indicator from this list on the left. You can see the trends over time for the indicators that I have selected for the 2 countries, thus enabling you to see how this varies over time and also to compare the trends between the 2 countries. And with that, I have come to the end of my presentation. We will be sharing the link to this dashboard in the chat, and it is also linked in our project page, and we welcome you to access this dashboard and interact with it yourself. Thank you.
Well, thank you so much, Lydia. That was a fantastic presentation, and I hope it gave the audience enough to go on and start exploring the dashboard on your own via the link in the chat. And also thank you to Kimberly and Trish for taking us through the status of scale for both calcium supplementation and low-dose aspirin. We are now going to turn to our moderated Q&A section to hear from an advocate on her perspective on how the asset tracker can be useful to advocates, to civil society in bringing together data and helping to tell the story and to advocate for certain policies. So I'd like to introduce Christine Yakahama, who is based in Kakamega, where she leads civil society work with the Alliance there. Christine, thank you so much for joining us. My first question to you is we'd love to hear more about when it comes to policies that support scaling interventions for mothers and babies. We know that there have been quite a few advancements in Kakamega County. So can you give us one or two examples of how the asset tracker helped build an understanding of the barriers that existed in Kakamega and how it helped overcome those barriers in your advocacy work?
Thank you, Catherine. Good morning, good evening. When it comes to the policies that support scaling interventions for mothers and babies, one of the barriers that is existing is the lack of access to accurate data to inform allocation of critical maternal, newborn child health and nutrition resources like medicines, vaccines, diagnostics providers, and also the funding. Two, we've also been having an issue with distribution of health products, especially from the national government coming to the county governments, whereby the national government doesn't consult the county governments on the kind of equipment that they want at the delivery points, to an extent that when they bring the equipment, you'll find they are not fit for the health facility, and again, they don't provide money for the technical expertise. So the asset tracker has helped us bridge the gap through data collation, comparability, and use. Hereby, we are having focus group discussions with the healthcare providers, and they give us the kind of equipment that they want and the commodities that they want, and we use those findings to influence the budget allocation. Thank you, Catherine.
Sorry about that. Christine, I have one more question for you, and it was really interesting to hear how you're using this data, particularly for budget advocacy. Can you say a bit more about how a tool like the asset tracker can help enable perhaps private sector, civil society, public organizations, or other communities in advocating for high-performing healthcare? And where do you see this going in the future?
Within the asset tracker, we have commodities and tools and approaches. And in those tools and approaches, we have whereby it can inform the population coverage, availability, and further the details on the extent of policy adoption and the progress of each asset, as well as we can be able to compare the country's progress to other countries.
Thanks. And I know we've had many conversations in the past about the availability of data and looking at the data at the national level and how that might compare at the subnational level. Is that something that you all have done in thinking about the data? I know in an ideal world, we would love to have all of this data in the dashboard at the subnational level, but even at the national level, how does that help you advocate in Kakamega County? Are you comparing progress in your county with the national level and other countries in the region?
I can give you an example. At the moment, we're having challenges with the polio vaccine, and that's happening at the national government. You find that now the advocates at the national government, they don't have the asset tracker to go about it. It's when now they're reaching to us to try and help them. be able to access the tracker to enable them also influence their allocations. And then one of the things that we are seeing is that if we could add other commodities in the asset tracker, it will be a plus. And also we can get other advocates instead of them coming back to us at the subnational level, because now at the moment, we are only Kisumu and Kakamega County advocates who are managing. It will be very key if the rest of the counties in Kenya would be also able to access the asset tracker to enable us, as we are influencing decisions, it doesn't just come from 2 counties, it be spread, and then we can speak one voice. For instance, like now it's really affecting our work because now the budget cut is there, especially at this 2024 budget. And if now we could have trained other counties on the asset tracker, it would have been a plus for us to speak as one. Over to you.
Thank you so much, Christine. I know that that is an area we've wanted to move to in the future, just working together with local civil society. Now that we have this framework established, how can some of these key milestones be collected by local civil society as a tool for having those conversations with local decision makers and policymakers, exactly as you say, to advocate for budget allocation. Some of these products maybe are not as talked about and need a little bit more advocacy. They're sometimes forgotten. And so I think the role of civil society in using that data to drive those conversations is really critical. So thank you so much. Thank you so much for your comments and sharing your experience from Kakamega County. I'm encouraging others to, I see some great questions coming in the chat, encourage others to add to that as well. Unfortunately, our colleague, the speaker, Zamzam Mohammed from Ethiopia, had a last minute conflict, as sometimes happens, decision makers getting pulled into other meetings. So unfortunately, we won't get to hear directly from her, but I have a few questions that I will instead ask my colleague, Nasibu Aganafer, who's based in Addis in Ethiopia, for his perspectives on some of what he has observed in how policymakers and decision makers are using the asset tracker and can use this data resource in the future. So Nasibu, I'd like to welcome you to the webinar. Thank you so much for joining us. Nasibu is a leader in our PATH office on maternal and child health as a senior team lead. So thank you, Nasibu, for joining last minute. So in your role in leading the data collection and analysis efforts of the asset tracker in Ethiopia, I wondered what you've observed in engaging with the Ministry of Health and other decision makers, other government entities. How have they used evidence from this analysis, and how do you see them using it in the future? I know we just shared all of the data locally last month, and so there was a lot of conversation there. So I'd love to hear your perspective. And Nasibu, you're on mute if you're speaking.
Yeah, thank you, Catherine, and thank you all for listening to me. Can you say the question again?
You were trying to join. Thank you. Yes, I would love to hear your perspective. You know, we just shared the findings in Addis last month. What is your perspective on engaging with the Ministry of Health, how they can use these analyses going forward to, to make their next actions to help scale up and advance these key interventions?
Yeah, thank you. Thank you. I think the experience we had during the simulation workshop and the feedback we got from the MNCHN colleagues and other stakeholders was, I think, important and encouraging. I can say that they have, from the MNCHN side, it was helpful. Framework we used in this asset tracker analysis, as well as the findings from this assessment, have already informed their activities. For example, currently there is revision of the national EML, the essential medicine list. So from the recommendation from the recommendation drawn from this assessment, they are working to use the opportunity of the ongoing revision of the EML to include some of our recommendation. One is on calcium supplementation, and they are working on that. So that's, I think, one of the way, or one of example that they are already using it. And the framework is very interesting for them, which would help to show the inclusion from the global guideline policies and international, and also which look into the health system components and goes to the coverage level. So across all those levels, it's important to assess and understand things. So they found that as important as well. And the dashboard is also interesting for them. It helps to see or to understand what is being done or the progress made in other countries, and also to identify some areas of improvement for the nation, and also to identify a country which could provide some experience sharing or some lesson for what they have implemented. Thank you.
Thank you, Nasibu, and thanks for bringing up the recommendations. That's an important piece of this project that we haven't touched on yet, but there's both the data dashboards where you can go to access the indicators that are available across the pathway to scale. But in addition to that, in the focus countries, there were 5 focus countries in this latest data collection cycle, we did develop an analytic slide decks to show the progress for each of the 8 interventions that we looked at in this cycle. And associated with that are near-term immediate actions or recommendations suggested from the analysis, as well as longer-term actions. And in many cases, there's usually a fairly strong policy environment for these assets, but there might be some small things that need to happen. Like maybe the intervention is listed in the EML, the essential medicines list, but it's not listed for the use case of interest for this maternal and child health use case. And so, showing that data for a set of assets and then advocating for it and putting that information in front of policymakers to take up as part of the next revision process for the essential medicines list is helpful. I think you also spoke to the framework a bit and how it can showcase where there's data, but where there are a lot of gaps. As I mentioned earlier, some of these interventions are quite new. They don't always have an indicator in a survey or in the HMIS. And I know there's a delicate balance between how many indicators get added. You can't necessarily monitor everything. But for priority interventions where we really want to know the status of scale, to know whether implementation is progressing, the asset tracker analyses really did help to highlight some of those data gaps and where more information is warranted if we want to be able to, in fact, know the status of scale. I think thinking about World Preeclampsia Day and low-dose aspirin, calcium supplementation, it's really part of a package of the antenatal care platform, and monitoring that does require individual adherence to that daily regimen. And so there are some monitoring challenges with that I think need to be explored a bit more. But in general, I think both of these interventions would be aided by further assessment in surveys or the like. Nasibu, are there any other reflections you have from working on this project over many years in Ethiopia? And you mentioned the framework and how it might actually be useful in other regards. That's a conversation that we've had, that this scale-up framework could be extended to other health areas. Would love to hear any additional comments or thoughts there.
Yeah, thank you. So during our discussion, during the dissemination and also during the validation workshop and during other opportunities, the suggestion from colleagues or from the MOH was to use the same framework and even to scale up this assessment to the subnational level, because this one is conducted at national level. And also they were suggesting or asking if this model could be used, it's open, available, and can be used for other health program areas, which can, where anyone can adopt this model and can use this model to conduct the assessment and also help the improvement and scale up of their specific or respective intervention program. So they feel it is very important and helpful. I think this is one of the things we heard from that.
Thank you, Nasibu. That's great to hear. And I know we all are thinking about where and how this might be extended to other avenues. I did see a question in the chat about cost effectiveness analyses. We did not include that at this stage, but I think it's a wonderful idea to think about what evidence. There's certainly a lot of cost effectiveness evidence out there for these interventions. So how to consider bringing that into the tracker would be something we're noting down for future iterations. I know there were some other clarification questions in the chat that Kimberly has been answering, but I wanted to give her an opportunity to voice over some of those explanations. So over to you, Kimberly.
Great. I just wanted to draw attention to some of the questions. They're coming both in the Q&A that you can review under the Answered tab, as well as throughout the chat. And we welcome more answers or questions in the chat or the Q&A as well. Both of those will work for our team. I wanted to specifically address the question on can a country use the asset tracker to assess progress at the subnational level? And Trish, if you have anything to add, please do. I answered this very broadly. We do have some subnational dashboards on our Journey to Scale website. And if one of my teammates can put that back into the chat, that would be great. That website specifically has all of the links, both to the data dashboard that we showed, that's across all assets investigated in Tableau. And it also has some more of the, since this project has been happening since 2019, there were additional deliverables along the way that were specific to some of the assets during that specific phase. So it was based on prioritization by Gates about location for priority countries, as well as prioritization of the interventions explored. However, there are, during phase 2, for the initial 14 assets of our 22, we do have some subnational data collection. It is not comprehensive to represent a full national picture. It was specific subnational facilities, as well as key informant interviews across different key informants at the subnational level. However, those are really interesting to explore. We just didn't have time on this call to go into depth of all the available information. So please take a look at that on your own. If you go down to the resources section on the website, there are other resources as well. Guides on how to use the dashboard, a country-specific example in Kenya around utilizing this data for policy and advocacy, so use cases. So really interesting case studies. I also wanted to draw, there were some questions on specifically on the definitions of the various assets. That is a great question. Wherever possible, the asset itself, if there is a WHO recommendation, we used how WHO describes or defines the intervention per WHO policy. If you have any question in following up with that, or what was included versus out of the question for inclusion, we are very happy to share additional information. So please let our team know if there are specific assets that you're interested in. I think some of the other questions were answered more easily in the chat. So that's all I had to share right now, but more may be coming in. So please keep those coming.
Yes, thank you so much, Kimberly. I know we're running up against the end of the time here. So we do have one poll that we would like everyone to answer. We'd love to hear more about, which assets you're most interested in. So if Kate, you could pull the poll up, that would be great. Thank you. We'll give folks a couple of minutes to answer this. I know there's it's a long list of interventions.
So the first question being, would you be interested in participating in an in-depth how-to session for the asset tracker dashboards? So we presented a very quick version. Lydia did a fantastic job to showcase each of the primary tabs and where, why you would use a certain data visualization tab when you want to do cross-country or in-depth in-country. But we would be very interested, if there is interest, to know how to use these dashboards more, or to do some self-testing to try it out as in a group setting we're interested in. The second question, we're really interested in where, for those joining the call today, where there's interest across all of the available assets. So which ones do you look to, are thinking that you may continue to explore?
Thanks so much for everyone who's chiming in on the poll. I see another excellent question has come in from our attendees, so I will answer that in a moment, and we'll wrap up this poll in about 30 seconds. Thank you again. It's really great to see which assets are of most interest to this particular audience. Thank you. Okay, I'm going to wrap up the poll, and thank you again. We will take this into advisement as we think about our next steps, and I'm going to share the results. Or Kate, if you're sharing the results. Seeing a lot of interest in joining a how-to session and having a deeper review of using the asset tracker. So that's great. We can think about how we'll plan for that. And then a lot of variability in which assets are of interest to this particular group. So thank you again for participating and sharing your interest in particular assets. Okay, so just to wrap up in our last few minutes, I see a question from an audience member about how the framework and simplified dashboards can be useful for subnational level tracking of specific assets, for adjusting strategies and advocacy in general. This is definitely an interest area of ours. We have been trying to consider how we might partner with local civil society, such as the Kakamega Alliance, to collect some of this data and to report on it. It's obviously would take a massive effort to do this subnationally across the country, but in partnership with CSOs, it could be possible, and to then get some of those key milestones integrated into a county or a state level discussion would be the goal to help drive the data for action discussion. I think we are interested in that, and we're looking for partnership on that. And so please reach out if you have ideas for how we might explore that further. But it's a well-noted point that the action is happening at the subnational level to scale these assets, and that more conversation is needed there on what needs to happen. And then there's a question on what is happening after 2024. So this is a good question. This project is wrapping up shortly in the next month, and so we will be transitioning this dashboard will of course remain available to the public, but we will not be updating it further with new assets or new data that becomes available. But a lot of policy indicators are going to remain valid. They don't change as often, and I think it'll still be a really helpful resource This database contains over 80,000 data points. It's a massive database where we've tried to aggregate from across as many secondary sources as we could. So I think that is one of the pieces that we leave behind from this project, that you can continue to access this dashboard for your needs going forward, even if it doesn't get updated beyond 2024. I'm noting yet, yes, we also agree that continued tracking of these interventions and publicly sharing the data is an important piece of and a need for the MNH community. And so I think this is just a starting point for future discussion of how that continues there are other dashboards and trackers out there. So how we can make sure that the data is available and updated accordingly. I know we're at time. I want to thank all of the attendees for joining. I want to thank my co-panelists for their excellent presentations. And I want to also thank the wider Asset Tracker project team and our collaborators. This has been a massive undertaking for the last 4 to 5 years, getting this much data aggregated and together and making sense of it. And it couldn't be possible without our partnerships in country. So thank you to everyone for taking our calls, collaborating with us, helping us access this data. We really appreciate it. And we hope that this data can be useful in starting conversations on how to unblock barriers, how to scale up some of these really key essential interventions. So with that, we will close out. We'll be sharing this webinar and the slides afterwards. So hope that you found this useful and can use this in the future and share with your colleagues. Thank you so much.